Good afternoon, everyone. Welcome to Wonder at Home, featuring the College of Medicine Phoenix. I'm Liz Kaplan. I'm the Senior Director of Development for the College of Medicine Phoenix. I'm sorry that Dean Guy Reed could not be with us today, but he does send his well wishes. I want to thank everyone for joining us today. I want to thank our donors and our friends of the college, especially for being with us today. It's my great pleasure to welcome our moderator, and he will introduce all of our panelists. Dr. Shad Marvasti is our moderator today. He is the Associate Professor for Family, Community, and Preventive Medicine. He is our Director of Public Health, Prevention, and Health Promotion for the College of Medicine Phoenix. And he is also a Professor of Public Health for the Mel and Enid Zuckerman College of Public Health. And now, Dr. Shad Marvasti.
Thank you, Liz, and thank you everyone for joining us today. With this event, we'd like to share a bit more about how the mission of this University of Arizona College of Medicine Phoenix has continued to flourish despite the challenges of the pandemic. Our mission is to improve the health of communities through distinction in personalized medical education, translational research, and patient care within a culture of inclusive excellence, as you saw images in the video that started today. With the COVID-19 pandemic, we've all been reminded about how highly complex and unpredictable and surprisingly interconnected the world is. So many lives have been touched, and our hearts go out to those who are no longer with us and the families of those who have lost their loved ones. The pandemic has been tragic in its consequences, but has also served as a great unveiler, unveiling to our eyes and minds things that many of us did not see or recognize as possible before the pandemic, and challenging us in so doing to look with wonder at all that we see as a result of all that we've learned. Here in America, we've recognized how the pandemic has unveiled before our eyes the value and the importance of the social, behavioral, and lifestyle determinants of health and disease. How your zip code can be as important, if not more important, than your genetic code. How the chronic diseases of our time with the slowed pandemics of those conditions have actually set us up for increased susceptibility with this pandemic, and why it's important for us to address those. As a regular medical contributor to represent our college with local and national media, I've also seen firsthand how important it is that the community and the public be empowered with knowledge that is based on science to protect themselves and their families. We've seen how misinformation can be challenging, and we've seen how science evolves and continues to change and must inform public policy in order to protect and save lives. We've also seen how the disproportionate impact of COVID-19 on underserved communities, as well as Black and Brown communities, as a result of longstanding systemic structural racism, has really pointed out to us the need for health equity in so many ways. And we've also recognized now with new opportunities for how we can connect, how we can provide care, educate, and really look at the virtual world like we are right now with this session today as a new tool in all fields. And in healthcare is no different, with telemedicine and innovations in medical education that you're going to hear about today, bringing us to our college, which really has been at the forefront of learning how to adapt with agility, to focus and teach our students these insights, which we've gained and are continuing to gain from this pandemic, to be able to still bring a high level of development and growth in the areas of personal medical education, translational research that will reach the community in empowering ways, and clinical care that really takes care of each patient in a very important and powerful way. So today, as part of the event, we've assembled some of our esteemed faculty and one of our esteemed graduating fourth-year medical students who will be literally graduating in a couple of weeks to answer some of your questions. And we appreciate you reaching out to join us today and also to send these questions ahead of time. So we'd like to use this opportunity to continue to achieve, adapt, and effectively respond to this pandemic through these areas of excellence as a college and as a community. So on that note, I'd like to begin to have our panelists first briefly introduce themselves.
Hello, everyone. My name is Justin Zeien, and I'm a fourth-year medical student, graduated medical student at the University of Arizona College of Medicine Phoenix, as well as a captain in the U.S. Army Medical Corps. In June, I will be starting my residency in anesthesiology at Walter Reed National Military Medical Center in Bethesda, Maryland, in fulfillment of the Army scholarship that I received at the start of medical school. At the conclusion of my residency, I will serve an additional 4 years as a U.S. Army anesthesiologist, and eventually I plan to return to Arizona to practice anesthesiology. I'm also the co-founder of Street Medicine Phoenix, a student-led initiative dedicated to serving the unmet needs of individuals experiencing homelessness in Phoenix, which I will discuss later. Now I'll turn it over to the next panelist, Dr. Glembotski.
Thank you, Justin. I'm Chris Glembotski. I'm professor of internal medicine here at the University of Arizona College of Medicine in Phoenix. And I'm also the new director of a new center that we call the Translational Cardiovascular Research Center, as well as the associate dean for research for the campus. In my roles as the associate dean for research, I've been tasked with, and I embrace the looking forward to the translational research, which converts our discoveries in the science lab to implementation on patient care. So translational research in all areas of particular importance to me, and I'm very excited to say that we're starting new programs, especially in the cardiology area, where we anticipate new discoveries being able to be implemented into the clinical practice as soon as possible. And our partnership between the University of Arizona and Banner University Medical Center, as well as several of our other clinical partners, are able to facilitate this exciting new research program. I moved here only 6 months ago with the express plan of making a big contribution towards curing diseases through translational research. So I hope to get a chance to talk to you a little bit more about that and answer some questions you might have later today. And I'd like to hand it off now to Dr. Sarah Coles.
Thank you. Hello, everybody. I am Dr. Sarah Coles. I am a family physician and faculty member at the University of Arizona College of Medicine Phoenix Family Medicine Residency at Banner University Medical Center. It's a mouthful. I have the very distinct pleasure of having done all of my training at the University of Arizona, so undergrad in Tucson, and then was in the inaugural class at the College of Medicine Phoenix. So I've got to watch it grow and change and impact the community for the last many years now. My work predominantly now is in medical education and broad spectrum primary care, meaning I take care of folks of all ages for just about any problem that you can think of in a number of different settings, including in my office, in the hospital, for pregnant persons, and in nursing homes. I'm also currently serving as the chair for the American Academy of Family Physicians Commission on Health of the Public and Science. And in that role, I do a lot of work on COVID-19 policy and clinical care, as well as broader areas in public health and evidence-based medicine. I'm really very happy to be here with you today to talk about family medicine and what the college is doing in COVID-19. And I'd like next to introduce Dr. Nathaniel Soper.
Hi, everyone. It's good to be here. My name is Nat Soper. I'm the chairman of the Department of Surgery here at the University of Arizona College of Medicine, Phoenix, and head up surgery at the Banner University Medical Center. The Department of Surgery is a large one, and it includes faculty members who are cardiac surgeons, lung surgeons, abdominal surgeons, colorectal surgeons, you name it. We have a faculty of over 100 individuals, many of whom are in private practice, but a large number are what we call full-time practitioners as well. Although we do research within the department, it's primarily clinical research, so we can look at outcomes and the quality of what we do from a surgical standpoint. But really the heart of what we do is clinical surgery and education. So we have a number of residents in our general surgery residency, and essentially that ends up being an apprenticeship, if you will, where they go through at least 5 years, going from an intern up to a chief resident, where they learn things as they go in all of the different areas. They rotate among the different specialties while they're here, to the point where after 5 clinical years, they would be able to practice surgery independently. And needless to say, COVID has disrupted a number of things that we do, and we'll talk more about that in just a little while.
I'd like to thank all the panelists for their introductions and want to begin now with some of the questions. And we'll start with a general question, and we can go in the same order, starting with soon-to-be Dr. Zeien. We've talked a lot about innovation and changes through the pandemic, and really some of the learnings and things that have been unveiled before us, and how, as a medical school, we've really tried to be adept in terms of adjusting and adapting to the new circumstances. So could each of you provide some examples of ways that you've had to shift the work that you do, and how we've been able to be innovative and continue to excel in the areas of focus that we have had as a college, despite the challenges and the limitations of the pandemic?
Sure. So our normal face-to-face outreach to the homeless population through the program Street Medicine Phoenix, which I'll describe a little later in more detail, was halted due to COVID. So we had to pivot. So one way we pivoted is we started using a portable autorefractor called QuickSee. It's basically similar to what the eye doctor uses to measure your vision in the office, but on a much smaller scale. We were able to measure prescriptions for glasses for folks living on the streets, and order glasses for dozens of individuals in need. These glasses have enabled folks to secure jobs and pursue educational degrees like their GED and even college degrees. One example is one student or one Army veteran wants to study to go to medical school, but he couldn't read the textbooks for the MCAT, the entrance exam for medical school. Once we got him his glasses, now he's able to read his MCAT textbooks, and hopefully he'll, in the next couple of years, start at the University of Arizona College of Medicine Phoenix as a new student. Another way our program pivoted is we started providing vaccines for COVID-19. So through the Johnson & Johnson vaccine that we received through the Maricopa County Department of Public Health, now we're vaccinating individuals experiencing homelessness so they're protected against COVID-19. And we vaccinated almost 100 people to date. In addition, we've accelerated our integration of mobile telemedicine technology, so we don't have to be there in person, but we can still take care of patients. And this way, patients living on the streets can still talk with physicians if they have medical issues, and we're not restricted by COVID-19, social distancing, mask wearing, those sorts of things. We're still able to provide our full spectrum care that we want to for our patients.
Wow, that's wonderful. Thank you. Dr. Glembotski?
Well, thank you for the opportunity to address this really relevant issue. In terms of a medical school, in addition to the education that you all know about, an important component is research. And the research we do is not only clinical, but also basic science research. Both of those kinds of research programs require researchers. In the case of clinical researcher, usually involves patients. And when it came time for COVID, we had to social distance and limit the numbers of patients that came to Banner, and for what they came to be addressed had to be limited to pretty much COVID patients at one point in time. And so the other research kind of had to go on to hold, but that's okay because we pivoted into research that was oriented toward COVID. And important amongst those research areas was pulmonary, because COVID is known to involve the lungs. And so we have a number of clinical trials that we started and completed during this brief time that COVID's been with us that improve patient therapy when they come in with COVID infection. We also, on the basic science side, were impacted during COVID because, as you know, one thing is that we have medical students in our labs, and we elected to not have the medical students coming in and doing research because of social distancing requirements. The labs are indoors and they're pretty small areas. And the major impact that this has had on people has been kind of a loss of workforce. And so we're expected to continue doing research at about the same level, but with fewer people. Nonetheless, our researchers at UA-CompP have pivoted in this direction and come up with very ingenious ways to keep doing research, some from at home. And that's one of the things that we learned that maybe we didn't know before. That was a good thing about the COVID pandemic, was how much we could do at home with regard to our research and still maintain our productivity. Importantly, from the basic science perspective, we also pivoted to COVID research. And one of the things we became interested in my center is how do drugs that patients who are heart disease or atherosclerosis patients affect their susceptibility to COVID and the course of the infection and the reactions afterwards. So we've done some really incredibly interesting research in this regard and found out that a lot of times patients are on pretty standard drugs that will actually decrease their susceptibility to COVID infection. And these were done in the lab, not with patients, but with drugs and heart cells in culture, so that we didn't have to treat patients with any new therapies that had not been tested. So that's one example of translational research. It's how we discovered things in our lab with regard to cardiovascular drugs that could be implemented in patients in the clinic that maybe were infected with COVID. But now it looks like COVID's on the downswing. And so we're ready to maintain our COVID research, but also keep implementing the new other areas of research and continue growing in that regard and hopefully helping out all of you. And in my case, in the new Cardiovascular Center, we're just getting off the ground, but we're so excited about the future. And now the future looks bright for all of us, I would say. So thank you.
Thank you. And indeed, the future looks bright because of all the legwork and the foundational knowledge that's been gained because of the basic clinical and translational research that's been done, right? That was really at the foundation and core at why we were able to nationally and internationally develop such highly effective and safe COVID-19 vaccines. If it wasn't for that long-standing investment in research and the time that it took, that technology, those technologies were put together over the period of decades in doing that research. And that's how, sometimes it suddenly translates right away into something that's very powerful, just like the mRNA technology, for example, with two of our safest and most effective vaccines. So great to hear about what we're doing here at the University of Arizona College of Medicine, Phoenix, in that area. Dr. Coles?
Thank you. It's such a huge question, as you know, Dr. Marvasti, because like all of us, right, every part of our lives were touched by this pandemic. And that's certainly true in medical education and in clinical care. Family medicine has always been a specialty that has been very dedicated to community medicine, population health, and prevention. So we were very natural allies to help fight the pandemic. But we even found ourselves having to expand and to reconsider how we provide clinical care, as well as medical education to people who are considering family medicine or who will be working with family doctors in the future, which is all of our medical students. So one way that we really had to broaden our scope was to think more deeply about the social determinants of health and equity that Dr. Marvasti spoke of earlier. So those are all the things that impact our health that is not necessarily directly related to the clinical care that you receive, what medicines are prescribed or what procedures you get, but things like your access to food and housing and transportation, financial support, or social isolation, all of which were, of course, devastated by the COVID pandemic. So in our office and in our practice, we had to really expand what we were doing to help our patients and our communities assess and address those because they had significant impacts on health. So one example in our office is that we expanded our emergency food box assistance program. So patients who come to our office can get a free emergency food box if they need it, if they're food insecure or facing hunger. This is a program that's spearheaded by one of the College of Medicine medical students who is also conducting research on it to see what the impact is of that in primary care. We had to expand our behavioral health services in primary care, as well as how we integrate lots of different health professions to build behavioral health programs to help support people who are dealing with stress and anxiety and depression as a result of the pandemic. And we had to start doing proactive outreach to our patients because we knew that many of them wouldn't necessarily think something's really going on in the pandemic. I don't have food, I don't have housing, I lost my job, I lost my insurance. They might not think I should call my doctor to ask these questions. So we started a vulnerable patient outreach program. We just started calling our patients and saying, hey, what's going on? How can we help you? What can we do? Let's start connecting you to resources. This was also spearheaded by residents and medical students in the College of Medicine Phoenix to help kind of reach those patients. The last kind of area, not the last, there are many areas, but another area that really kind of had to shift and change was our involvement in science communication and helping to get people good, accurate information to help make safer choices during the pandemic. So we have to battle the twin pandemic right now of the infodemic, which is an overwhelming abundance of information that is fostered by the internet and social media. Much of it is misinformation, so information that's wrong, and disinformation, information that's intended to help people or to cause people to make decisions that maybe are not in their best interest. So figuring out ways to battle the infodemic by going to our patients and our communities outside of our offices and outside of our hospitals to get them good information. And that can include traditional outlets like newspapers or television or radio. But I think even more importantly includes social media and the internet. So in our office, for me, I've become an editor and author for a social media platform called Dear Pandemic. This is an innovative multidisciplinary science communication project that's specifically aimed at combating the infodemic. And it's all women clinicians and scientists that are working together across 4 different social media sites to try to help people know what's good information out there, use some analytical thinking to figure out what's great and what's not so great, and to answer some of those really hard questions that maybe not super easy to find the answers to. And we started training our residents and medical students about how do you do that? How do you communicate more broadly with the public in the face of a pandemic? But once the pandemic's gone, misinformation and disinformation will continue. So how do we help people build that broader scope of communication practice?
That's great. Taking that multi-pronged, broad approach, right? Not just limiting ourselves to one patient encounter at a time. I think that's definitely part of our bread and butter in terms of the culture of primary care, speaking as a family medicine physician myself as well. But it's so important as a College of Medicine and as a university, Banner University Medical Center with the residents to really look beyond the walls of our clinic and understanding the interface and the impact that we can have with that interface with the public, right? And directly with the community. Thank you, Dr. Coles. Dr. Soper.
Wow, I've been blown away by what everybody else has been doing during this time, because for a department of surgery, it's essentially been head down and periscope up and get the work done. Most surgery, probably 2/3, is what we call elective. That is, it's not an emergency, not urgent. And that was essentially shut down for months at a time during the pandemic. But that meant we needed to take care of patients with cancer that was relatively late stage, that couldn't wait, people with acute emergencies like appendicitis or cholecystitis or things like that, and trauma. And also the surgeons our trauma surgeons are also critical care boarded. We took on COVID patients and ran COVID ICUs as well. And it's very difficult to treat a bunch of people at one time, as Dr. Coles was talking about, working with many. This is one-on-one, and the active surgery is a very dangerous time in taking care of COVID patients, both for the intubation, but also for very close contact that is necessitated when we do this sort of thing. So we had to totally readjust all of our schedules and move people around to be able to take care of the sickest patients. Move actually our trainees back from other hospitals where they weren't taking care of as many COVID patients. So it really disrupted much of what we do on a daily basis, but also redirected what we did. And some surgeons who had done intensive care unit in the past, but not recently, were re-educated on what needed to be done to take care of some of these sickest patients on ventilators and things of that nature. So, and needless to say, it disrupted all of our educational activities. As a chair of surgery, I was recruiting new faculty members all on Zoom. And that's a whole different experience as well that we can talk about. And all of our educational experiences for our residents and medical students were changed dramatically. And some of those things will continue on because they actually work pretty well. But I can tell you, we are going to be very happy when we can get back in face-to-face encounters for much of our teaching activities.
Thank you, Dr. Soper. So it appears that there has been great disruption, but some of that disruption has also led to new innovations in terms of our approaches and continued resilience as well, with all the turns and twists here. And in looking at kind of all of our panelists, which we just heard right now, you can see the broad spectrum that the University of Arizona College of Medicine Phoenix really takes at addressing the issues and the challenges from the laboratory bench side to the patient bedside, and beyond that to the community park bench, if you will. So we're kind of all over the place in terms of our approach, and you really need to be to have that holistic kind of broad perspective. So looking at specifically the issue of the impact that the pandemic had on training, education, and the application process, I think Dr. Soper, you started to touch on that. Maybe you and Dr. Coles can speak a little bit more about that impact and how you had to pivot and what that looked like.
So I'll really concern myself most with our residents and let Dr. Coles talk a little more about medical students if she wishes to, because many of the medical students were actually removed from the hospital during much of this period of time to protect them from being infected. So we actually had about 15 to 20% of our residents ultimately were infected with COVID. And so we had to put in place teams that would cover, there would be two separate teams that would cover 12 hours at a time, and they would never get together so that if one group were infected, the other group wouldn't become infected. And so that's how we kind of ran the clinical shifts, if you will. And so we had shifts in the trauma unit, in the intensive care unit. We had to have nighttime coverage. And this is how we redirected the residents during this period of time. From an educational standpoint, we ordinarily do a lot of hands-on things, simulation labs, all of that sort of stuff, usually in one morning of the week, all in person. And of course, this all had to be changed. So it was largely on Zoom. When we had simulation labs, there were only a few people allowed in the lab at any one time to be able to do these practice sessions of how to sew and how to put things back together when it's been taken apart, and all of how to do laparoscopy and that sort of thing. We have labs that can simulate all of those things, and those need to be changed tremendously. And finally, in terms of being able to apply and what we did with our resident selection process is ordinarily we would have 120 individuals come from all over the country on 4 different dates and interview. And in fact, this time we had, I think, 6 different Zoom days where there'd be 15 people or so on Zoom calls and have to try to evaluate them simply online. And I must say, one of the real positive things about our residency is the camaraderie and the way people get along. And some of that was lost in the shuffle. And that was really too bad that we couldn't really show off as much as we might have otherwise. But it really changed how we do things. Now, in the future, I would suggest that we will continue to do some of that. But we had to kind of think about it on the fly. And I'm sure we could have done better at the beginning, but we're better now than we were at the start. Dr. Coles, what about in your area?
Yeah, a very similar experience in the family medicine residency, where we had to make dramatic shifts in not just the clinical care, but how we are teaching our residents to provide clinical care moving forward. We similarly cohorted, so had groups of residents, physicians, and our team members, so like our medical assistants, our front office staff, that would work different shifts so that we weren't intermixing as much. So if somebody became infected, we were less likely to hand it off to each other. And then we figured out very quickly that we had to figure new ways to teach, because we traditionally do a lot of our teaching in person, hands-on, lots of kind of interactive teaching. And we could no longer do that quite the same. So we had to get very good at situations like this, where we would teach over some kind of video conferencing platform, and quickly learned that just talking at people wasn't very effective. So just giving a lot of lectures was not the most fun for our learners or our presenters, but also just wasn't as engaging, or interactive, or effective as teaching. And actually, I'm sure Justin can weigh in on this as well. But so we had to figure out, how do we have interactive space? How do we keep that interpersonal dynamic that could get lost when we're not able to talk face-to-face? And how do we teach people care that is a lot of touching persons without being able to touch anybody or be in the same place? So did some interesting things with simulation. We had a sim night with our students where we mailed them or had them pick up fruit. And we did skin procedures on fruit at home over Zoom. That was led by all our residents and our medical students. And you just had the camera down on your hand while you're kind of watching people work, to teach them some sewing, biopsy techniques, those kinds of things. We've done a lot of case-based teaching, so practice cases with patients, and then a lot of starting to bring patients into our telehealth visits. And we'll talk a lot more about telehealth, but getting our residents and medical students involved in providing direct clinical care, even when we can't be in that same place.
That's great. Yeah, it's definitely been a pivot as a medical educator myself. I've just seen how much is possible. And you kind of alluded to the need for a flipped classroom approach where, learners can look at, key content in a little short video ahead of time, and then come into the session with application right away, getting into problem-based learning, case-based learning, which I think is really helpful and fruitful. So it's actually taught us a lot of things in terms of what can work that we may not have even thought about, and kind of put us ahead in the medical education side. And speaking to that side, I'm going to ask soon to be Dr. Zeien to comment a little bit for us about the experience from a medical student perspective, and how you're able to continue serving the community. This is one of the questions, despite having to quarantine in home, and also for that matter, advance your education. And anything else you want to share a little bit about Street Medicine Phoenix as well.
Sure, thanks for the question. So in response to the pandemic, University of Arizona College of Medicine Phoenix students, with the support of staff and faculty, organized to create the COVID-19 Student Services Corps. So this initiative consisted of service programs in several categories, including PPE programs, helplines, food resource donation programs, and epidemiology programs. So through these many programs, students volunteered to make hundreds of masks. They collected PPE donations for under-resourced healthcare centers, like in the Navajo Nation, when they had their peak spike in cases. They performed contact tracing for those exposed to COVID-19. And they staffed the Maricopa County Health Department COVID-19 call center, where they fielded questions and answered questions about the COVID-19 virus, safety measures like mask wearing and social distancing, and then more recently, questions about the vaccines. And volunteers also raised funds for thousands of meals to distribute to hospital workers across Arizona, and they collected hundreds of pounds of food and clothing donations for underserved and vulnerable populations across Arizona. Many of these donations went to community agencies like food banks and shelters that directly help individuals experiencing homelessness in Phoenix. And that kind of segues into Street Medicine Phoenix, which I'll briefly talk about. It's part of the Street Medicine Initiative, which is a coalition of over 100 street medicine programs across the world, both nationally and internationally. Our group is composed of volunteer students and faculty from not just the University of Arizona, but also Arizona State University, Northern Arizona University, and Midwestern University, who provide outreach to individuals experiencing homelessness across Phoenix. Our team consists of students and faculty from many programs, including medicine, nursing, pharmacy, veterinary, optometry, social work, physical and occupational therapy, and undergraduates from Arizona State University. So equipped with backpacks containing medical supplies and various donation items like hygiene supplies and socks for our patients, we literally walk the streets of Phoenix and through the parks looking for homeless encampments. And there we provide services, including health screenings like blood pressure and blood sugar. We provide wound care and other acute medical care. We provide sexually transmitted infections testing and much, much more. In addition, we provide referrals to community resources as needed by our patients, including shelters, food banks, as well as community health clinics that can provide low cost or free long-term health care for our patients, so they're not just relying on us to provide them with the health care that they need. And then although Street Medicine Phoenix couldn't provide the normal outreach as I described earlier due to the pandemic, we were still able to provide the glasses as well as different food, clothing, and hygiene product donations to our partners in the community to continue serving the homeless population that we normally serve in the pandemic since we couldn't go out.
That's great. It's so wonderful to hear what an impact we can and are continuing to make in the community and being in really embedded in the community, as was mentioned before, to address these social determinants of health, oftentimes more important than we had originally thought, and major contributors to the diseases of our time. And speaking of different ways to approach things, I think Dr. Coles, you mentioned a little bit about telehealth. So one of the questions we wanted to address is, how did clinical care change and adapt to meet the needs of patients and communities during the pandemic. And with that change, obviously, one of the biggest changes in all of our practices has been the expansion and development of telehealth and telemedicine. Do you think that this is going to continue to be a popular option for patients after the pandemic, and what implications will it have for our whole healthcare system?
Yeah, telehealth has been one of the, I think, really bright spots of the pandemic. Before the pandemic, very few of us were actually offering telehealth consistently as a clinical care option. It might be hit or miss. There were some places that were doing it, but this was not really widely available to most people, at least in primary care, in urban centers. So, February comes along, and by March, the use of telehealth has increased almost 150%. We all had to learn very quickly how to adapt to this new technology in our clinical care and in our teaching strategies as well. I have personally seen telehealth just blossom into something that's fantastic, and it's become one of my new favorite things to do is to get to participate in telehealth visits. Many of my patients have a lot of challenges and struggles. I work in an urban underserved practice. So my patients have difficulty getting time off work to come to the doctor, or they don't have transportation, or it's 1,000 degrees outside and they're having to walk to get here, and that's really challenging. Or they have nobody to care for their kids or their loved one who they're the primary caregiver for. And telehealth has given us the option to reach them where they are and to still provide them needed clinical care. I was pleasantly surprised how much you can do over telehealth, how much you can really care for somebody over a video or over the phone. It definitely took some getting used to, and we had to figure out how do you make those emotional connections, how do you take a good history and find out what's going on, and how do you do some physical exam stuff over video, which is really fun and really cool, and you get to do some things with your patients. We also get to see where they live and what their life circumstances are. So I've had patients walk me around their house to show me what's going on with their home. What do the medicine cabinets look like? What kinds of barriers are they facing? Do they have stairs that they can't get up? And so telehealth has been, I think, really a blessing of this. I have no doubt that telehealth is here to stay. There is no way that genie is getting put back in that bottle. So I'm really excited that telehealth will continue to be an option for many patients. There will be struggles moving forward, particularly in terms of policy around telehealth. Who can get telehealth? How do we make sure that people have access to telephones or broadband internet so that they can have a video encounter, as well as clinicians, how do we bill for it? How do we use that time wisely to make sure that we're providing the best available care that we can? But I'm really thrilled to say I don't think it's going anywhere.
That's great. Yeah, I think, as you said, once the box has been open, we can't really close it. So it's really these unlimited possibilities that we didn't know about before. Now we've been tested, and we've gone into this new frontier. So hopefully onward and upward from here. And speaking of that, in terms of continuing to expand our knowledge base and develop innovation, Dr. Glembotski, in terms of the challenges with research, you started to talk a little bit about that at the University of Arizona College of Medicine, Phoenix. You talked about the shifting nature of the research focus on COVID-19 with the pandemic and inability at points to do research in other areas. How is that continuing to evolve in terms of what specific challenges did you find, and has there been an impact because of COVID-19, the pandemic, on research funding and kind of the direction of research in general, in the scientific and medical community?
Well, thanks for the question and the opportunity to speak on this topic. So I wanted to just emphasize that research and education are two very, very important things our medical school is immersed in and that we do. And it could be research at very different levels in very different fields. Sometimes the research is in cardiology or neuroscience or psychiatry, and sometimes it's in infectious disease like COVID. So the research is funded often by the National Institutes of Health, which most of you have heard a lot about in the last months, as the National Institutes of Health have been an important spearhead of organizing the COVID vaccine distribution especially when it comes to distributing public knowledge about this. Well, the NIH gave us money, if we're successfully competing for it, to do research in these different fields, sometimes the year before COVID, sometimes even 2 years before COVID. And they did not see coming that our research was going to be impacted because of COVID. And so we can't stop doing research because sometimes it takes many years to get to that point in research. And once you stop, it just like sends you back 10 years or so. So somehow we had to keep doing this research even with a limited workforce. And I'm proud to say that University of Arizona College of Medicine in Phoenix did continue in that regard and followed social distancing while still being on site doing research with very, very low infection rate. And so we were very successful with that. But in my office as the Associate Dean for Research, I was responsible for maintaining the safety of everyone on campus, both at the university and at Banner University Medical Center. So this was a huge responsibility because I, even myself, was not able to come and put an eye on the locations and see how things are going. Having said that, they went extremely well, and research funding actually has gone up a little bit. And I think that is a little bit due to the momentum that we had before COVID came along, and then the pivot to doing some research at home in order to further what we can do. Depends on the field as to whether you can do that. And then the pivot also to COVID research. And in some people's cases, that COVID research has turned to vaccinology in general and other things that pandemics that might come down the pike in the future for us. So I'm really proud to be a member of our faculty and our community because I think that we've really risen to the occasion. And in terms of medical schools, put Phoenix on the map, right where we needed to be, right in the heart of Phoenix, where the patients can be treated the best. So I'm very excited about what the future holds in all of these new areas that have kind of expanded our purview. And I mentioned NIH, and this gets me back to something that Dr. Coles talked about with information transfer and understanding. And it's an important thing to realize that sometimes science tells us what we thought last week was the way to go is different this week, or even today or tomorrow. Those of us who work in the clinic and the lab understand this. Oftentimes, though, people maybe who aren't in our field say, why did Dr. Fauci say this thing yesterday and something else today? And so he's an excellent communicator, and he gives it the straight story. And so it's probably because the findings have slightly changed or the data coming in changed his viewpoint. This is an important aspect of education, educating not only our medical students to understand how important being able to, as a physician, pivot quickly when the data change, but also communicate with patients who maybe don't have that depth of experience and understanding that we do when the data change, and understanding their viewpoint in that regard. So thanks for the question.
Thank you very much. And speaking to changing, the data, I think we continue to see an evolution of science, right, as new data becomes available. And that's kind of what you were talking about, and going back to the concept of effective communication in terms of science and correcting misinformation that Dr. Coles was mentioning in terms of the work that her and her group are doing. So critical to understand that and look at kind of how things have evolved in this pandemic and recognizing where we're at right now. I know one of the questions was talking about kind of where are we at with the vaccines and the variants. And just very briefly, I'll just share that, we're really in a race against time with these variants, right? So what we're seeing is that in places where we've had greater uptake and percentage of vaccination, because of the vaccines being so highly effective against the variants that are out there that we know of to date, we are able to get people to be safe and protected. The cases of breakthrough, infections, and those who are fully vaccinated is so small. It's a very, very small percentage. And the majority of them, over 93% 3%, I believe, on the last check, are very mildly symptomatic, not requiring hospitalization. So when you look at that and you look at the fact that COVID-19 has long COVID, or post-COVID syndrome, as we're seeing now, long-term, you don't want to get this. So now that everyone can, at least thankfully in the United States, get the vaccine, the best thing you can do is to get vaccinated, to protect yourself and the community, and for us to get back to some level of normalcy. And if we let go of the mask and we let go of the medications too soon, then we leave open the space for these variants to come in, right? So don't be confused by what's out there. The vaccines work, they're safe, they're effective, and we are seeing the light at the end of the tunnel. And thankfully, we can kind of build on these silver linings that we've heard and that our college is working towards. And speaking of kind of continuing to sustain some of those, I wanted to ask soon to be Dr. Zeien to tell us just a little bit, what kind of funding is required to keep some of these things sustainable? Because what you were talking about sounds like a vast undertaking, engaging the homeless community, doing so much, right, in terms of these services. I'm sure that costs and requires a number of resources. What do we need to make that sustainable? What are the funding needs there?
Yeah, thanks for the question. So Street Medicine Phoenix sustainability is really three-pronged. It requires strong student and faculty leadership, partnerships with community agencies that service individuals experiencing homelessness, as well as the funding aspect that you mentioned, the continuous in-kind and monetary donations from both charitable organizations and community members. So to answer that first part, the strong leadership, since I will be transitioning out as well as the other co-founder, what we've done is identify 2 current third-year medical students at UA-CompP, as well as a junior at Arizona State University to take the helm. And these leaders have the responsibility of continuing to carry out Street Medicine Phoenix's mission and finding other passionate student leaders who will carry the torch when they leave. We have also identified many faculty physicians at UA-CompP and faculty at other universities as well who can advocate for our program and are passionate about teaching and mentoring students. Secondly, collaborations with community agencies are important because they enable our team to coordinate resources and best meet the ever-changing needs of the homeless population. We share our research and lessons learned with these other organizations to ensure that we're meeting these needs, especially during a pandemic such as this, when the needs may shift greatly and the homeless population is increasing quite rapidly, quicker than we anticipated. Lastly, we would not be able to provide the care that we do without the generosity and support of donors from both charitable organizations and the general community. All of our medical equipment and supplies are 100% funded by donations. And so in addition, we provide hygiene care kits, socks, feminine hygiene products, and other essential items to our patients, which we either collect from donation drives or purchase using monetary donations. So this continual stream of funding is important for programs such as Street Medicine Phoenix and other programs across Phoenix that service underrepresented, underserved, vulnerable populations to ensure that they continue, especially during times like the pandemic when many grants are unavailable or a lot of funding sources are currently unavailable.
Right. And you're pointing out also the economic devastation, right? We have so many more folks who are homeless or food insecure, lacking the basic access to care and their basic needs. So really, this is a time when we can, if we can, to give, to be able to do these programs in our college, kind of being at the forefront of many of this, like I said before, from the bench to the bedside to the bench, park bench, right? We're kind of trying to hit on all those areas, and there's programs, everything in between. I want to invite any of the folks who are watching right now also to send us your questions, if you have any, as we're kind of wrapping up here, getting towards the end. We'd love to entertain any of those questions, so please feel free to type them in the chat and submit them now. Otherwise, I'd like to ask any of our panelists, as we're kind of waiting for any more questions to add, what viewers need to know in terms of supporting the work that they're doing, and what can be helpful, and what is needed in terms of resources. Maybe we can start with Dr. Soper.
Well, we have so many missions that we try to accomplish at once that it's hard to really say what is the one that we need the most. We're doing some very cool stuff. We're putting together a fellowship for space surgery, working with SpaceX, and this is going to be starting actually this summer. We will be the only place in the United States where people will be able to come and get trained with an ACGME approved program in space medicine, but it will be focused on surgery within low resource settings, such as you might find on Mars or something like that. So that's one very cool thing we're just getting up and running. The other thing is we expanded our residency program this year by one individual, and we're starting a rural surgery track within our residency program for people who are interested in going out into the areas that are underserved with surgeons. And so, again, this is another new area that we are just taking on this year. As we see, it's one of the missions of Phoenix and what we're doing here in surgery to be able to go to the underserved and be able to take care of them, as well as the people here in Phoenix can be taken care of at our own medical center. So those are just two things I'd throw out there, and I'm sure some of the others have other ideas as well.
Thank you, Dr. Soper. Dr. Coles?
Yeah, there's so much opportunity to help support kind of all of these areas. In family medicine, in our department, we have a number of programs that we're continuing to work on to try to expand into our community and to both help with the pandemic and then looking forward to the future. So as I've already mentioned, our food assistance program in our office, our behavioral health program, we've also started a fluoride program for children because dental cavities is the number one chronic condition in children in the state of Arizona, and many, many kids don't have access to a dentist. So we're expanding that in primary care. We're also really working on how do we work with, as soon to be Dr. Zeien was talking about, how do you do these public, private, and community partnerships to expand care for all sorts of folks. And for us, one of the areas we're working on is schools. So early childhood education and education about science literacy, health literacy, STEM education, to encourage folks to both pursue all of their educational opportunities, to find new educational opportunities, and hopefully to be a pipeline to be new doctors for the state of Arizona. Selfishly, we would like them to be primary care doctors because of the primary care shortage, but there's shortages of everybody. So working out there. So we could use any help that we can get from anybody, which would include your time, your talent, and your treasure, right? So we would like volunteerism for all of those things. So anything that you're willing to give is super helpful. Thank you.
Thank you, Dr. Coles. Dr. Glembotski?
Yes, I think it was Justin who said that this program has a three-pronged approach to it. And the same is true with the University of Arizona in general. First of all, it's about the people. The most important thing is the people. And the people who work here, like the panelists you see, as well as the people of our community. Secondly, it's funding from large organizations like the National Institutes of Health to underwrite the research programs in both our clinical and basic science research settings. And the biggest challenge, I saw one of the questions about what's our big challenge coming up. That's our big challenge coming up. We're just at the precipice of becoming one of the greatest medical schools in the country. And in order to make that leap, our research enterprise has to grow accordingly. And so we have to hire physicians and hire scientists who are invested in translational research in order for us to move up that category. And then the third one is community philanthropic support. We need that in our hospital as well as our science labs. And one example is Dr. Soper himself is the recipient of a professorship that came from your donations and your support. And that's an example of how we're able to hire and recruit the highest quality faculty only with all three of those prongs acting at the same time. So that's my closing statement and an answer to one of the questions.
Yeah, thank you very much, Dr. Glembotski. I think that last question also I'll chime in on is, what are some of the challenges, as you pointed out specifically on the research front? I think it's also continuing to be bold in our vision, to engage the community and really innovative partnerships across all lines. I think one of our greatest strengths is our educational enterprise. We need to build on that and the connections and collaborations that we've created over the years as a college to buoy our research and also to really continue to raise visibility for the diverse work that we're doing here at the college. I think a lot of people don't know how much is being done here at the University of Arizona College of Medicine in Phoenix. It's not just in Tucson, which is great, but it's right here in Phoenix. So come check us out. Take a look at the website. We're going to be here for you as a resource. We want to continue to engage the community. And I want to thank all of our panelists at this time for their time, for their expertise, and for their input and their willingness to answer these questions. Thank you all so much. And thank you for everyone who attended. A recording of this discussion will be available and sent out to all the attendees, as well as online, I think, for others to continue to share. And we will definitely continue to have more of these events to continue to share what we're doing, keep you informed, and keep connected with you. Thank you so much.